Good evening, ladies and gentlemen. Yeah, welcome to the EthiQal webinar. And this webinar has got one ethics point. It's accredited for one ethics point. My name is Hlombe Makuluma. I'm the medical-legal advisor at EthiQal. Just a few things that we just want to take aside as we start the webinar. I've got two presenters here, Dr. Johannes van Waart, who's the president of FoSAS. He's going to talk to us about, we know that we've been on the lockdown for some time, elective surgeries have been stopped, but maybe as we go through the different stages, how do we cautiously go back as surgeons to work, to start our operations or to start our surgeries? And we also have JP Ellis. JP is our legal and claims manager at EthiQal. He's going to talk to us more about some of the questions that you guys have asked, mostly about the informed consent, basically related to COVID-19, and also about your rights and obligations. We know that there are some hospitals that already have sent out some information about what is expected. So let's hope for a very interesting talk. If you look at the bottom of your screens, we'll address your questions. Please submit your questions so that we can answer them. We also understand that there are people that maybe did not register, but have received a link to attend, and they are attending. If those people are interested in getting their CPD points, please send us an email at info@ethical.co.za with your name and your surname and your MP number. Then we'll be able to email you a CPD certificate. In the next 2 to 3 weeks, we'll be able to do the CPD certificates. The questions that you guys sent during registration will be addressed throughout the presentation. And at the end of the presentations, the ones that you have written and some that were not addressed, then we will also address them. Just one last point, the webinar is being recorded, and we hope that our IT and our technical gurus will be able to upload it sometime on our website so that you can share the webinar with people who could not attend, or you can go back to our website and have a look at it. Without wasting a lot of our time, can I hand over to Dr. van Waart?
Hlombe, thank you very much. It's a great privilege to be here tonight, and thank you for the invitation. I'm just going to get my presentation up so that we can get that going. Okay, so I hope it's up there. So this document that we put together is a FoSAS consensus statement on the resumption of elective surgery. And this document was drawn up on 26 April. So at the moment, this is how currently it stands. And I will bring up some of the points relevant to this statement as well. So let me just get... Sorry for that. I am just trying to go. Okay. So I think this current document is a set of principles to help local facilities with the guidance of their local COVID-19 committees for the resumption of surgical care in South Africa. That goes not only for the private sector, but also for the public sector. We wanted to put appropriate steps there to support the measures that will flatten the curve, and I think that was the whole purpose of the lockdown. And this should be seen as a dynamic document with the recommendations being effective at the time of issue. But this might be updated or changed at any time. And at that point in time, if we do that, we will communicate to our members. Now, for the purpose of the document, we put surgery into 4 different categories. And we tried actually to avoid the name elective surgery because there were some issues with medical funders of saying elective surgery is things very often that should not be done. and that could be done and then is done by surgeons in hospitals. So I think the better name for this is called discretionary elective and essential surgery, meaning that it's something that can be delayed by 3 months, but probably not a lot longer than that in order to get patients to have a better quality of life. The second one is essential surgery, which is surgery that can be extended longer than 2 weeks, but no longer than 3 months. The third one is urgent essential surgery. That is surgery that should be completed within 2 weeks. In other words, the patients will probably have problems if you postpone that in terms of quality of life and health outcome. And then the last category is emergent surgery, and that is surgery that should be done without delay and making sure that the patient is medically stable before this is done. So I think these 4 categories are there to guide us in order to class or put your surgery into one of those categories to help you to make a decision and your local committee on when it should take place. What are the considerations that should be weighed up? Firstly, the judgment as to whether or not a surgical intervention should take place can only be decided once numerous considerations have been observed. I think there are a number of uncertainties in this whole process, and some cases might be delayed just for reasons of the COVID-19, but they might present quite soon or even in a month or 2 from now, and then present as an emergency, which will make it not a very good idea to continue then. So I think the judgments should be based on not only one consideration, but in the broader context of things. I just want to get this up. Sorry, this, let me just put this up again. There we go. Sorry for that. There we go. Sorry. All right. I'm just going to put that on again. Okay. So let me go one back. All right. What are the recommendations? I think hospital and surgical teams should consider both their patients' medical needs, but also take into account the logistical capacity. I think in this time where the world actually is short of supplies in terms of PPE and a lot of other necessities, I think it should be taken into account what's available at your local facility. The medical need for a given procedure should be established by a surgeon with direct expertise in that relevant field. So I don't think it's proper for a gynecologist to make a suggestion or make a judgment on somebody who's got something like an orthopedic emergency. But this should be relevant to that speciality and taking into account the medical risk, which can be or can come into play if there's a delay. The logistical feasibility for the specific procedure should certainly be determined not only by the doctor, but also by the management of the specific institution and also the community limitations. In other words, one should take into account the beds, the staff, the equipment, and everything else that plays out in a specific component. So the recommendations are, the case conduct should be determined based on the knowledge of national, but certainly also of regional and even more important, local evolving conditions. And what we should do is do regional decision making. We know at the moment that the Western Cape is a hotspot, so certainly the decision in the Western Cape, especially in the Cape Metropole, should be made differently from some center in Limpopo where the evolving conditions are actually a little bit different.
Just not to disturb you, Johannes.
Yes,
just
sorry.
Please share your screen. We can't see the presentation itself.
I am sorry. I will do that.
Something you forgot that, please.
Okay, let me do that. Sorry for that. Okay, there is the share the screen.
Yes.
There we go. I'm sorry for that. There we go. And we'll just go to...
there we are.
There we go. I'm sorry. So the recommendation, the case conduct should be determined based on the knowledge of not only evolving conditions in the national arena, but also in the region decision. And the risk of the delay should also be taken into consideration. So in general, there should be a committee that makes a day-by-day, evidence-driven assessment, and one should avoid blanket policies where there's a one-size-fits-all. But it is important that when the decision is made, that there should be an understanding of all COVID-19 issues at play. And it should not only be based on the COVID-19 associated risks, but rather on the simulation of all available medical and the logistical information. I think this is a critical part, that one size does not fit all. Now, if we come to the diagnostic testing, we must remember the anaesthetists are the frontline people along with the physicians, and they've put on a very good statement from their society called the Pragmatic Approach to Surgery During COVID-19 Period in South Africa. And one should read this specific document, the FoSAS document, in association with this document from the anaesthetist. So I think it is important that one should know your COVID-19 diagnostic testing availability. You should know and certainly have an operational testing policy. You should know the turnaround time of these tests. I think it is important to develop a local diagnostic testing policy because there might be different turnaround times in different regions from different labs. There should definitely be surgeons involved in this institutional policy making. And I think very critical, there should be allowed some surgeon discretion. And the reason is that because you as a surgeon know your patient the best. And I come back to the point that a blanket policy is not on. So certainly that should be a dynamic decision, taking everything into consideration, consulting the anaesthetist and searching the surgeon should be the one to make the final call. I think there should also be a screening testing policy for healthcare workers specifically. Also make sure that you consider the false negative test rates, and in that instance also the need for retesting. Make sure there are some guidelines for post-operative COVID-19 testing of symptomatic patients or patients under investigation, and that specifically is for patients who start developing symptoms after they've been operated, and whether one should retest them or just take them to have some different, something different at that point in time. As it's not likely that would be a highly sensitive and specific test available that could be used for everybody for the least or for the next number of months, I think there should be reasonable alternative methods of determining risk versus benefit to the patient and public health in all facilities. And I think this is something that one should develop per institution, taking regional and local risk factors into consideration. And I think it should be implemented, and alternative screening methods should be taken into consideration from time to time. Informed consent, very important. And I think one should not only consider the procedure-related risks, but also your patient should be informed of the COVID-19 associated risk. In other words, the chance of contracting disease in hospital. And it's very important that this should be in writing and that it should be done by the surgeon involved. And I think this certainly has a big medical legal implication, and I'm sure JP will allude to this later on in the presentation. So now coming back to the reality and the practicalities, I think it's important that one should ensure optimal patient care across the 5 phases of care. The phase 1 being the pre-operative period. And I think here telehealth is very, very important. And I think there should be a guideline for repeating laboratory tests. So I've had a patient today who had a test done 10 days ago, and she's in for surgery tomorrow. And I think that's certainly a little bit long in that window. So we've decided on the local committee that patients should be retested, and we're going to postpone the procedure for a couple of days. I think it's also a good idea to have all your patients informed of getting the influenza vaccine. I think this is the wrong time of year to get symptoms that could simulate the COVID symptoms and to find out it's flu and you've been hospitalized. I think it is quite important, especially for the patients at high risk, to have this. Make sure that you assess or reassess the comorbidities as you would know your patient quite well. I think practice physical distancing, especially in your surgeries, so rather use the telehealth. Make sure that you understand the patient's potential needs for post-acute care facility, because those patients are going to need some care once they are discharged from the hospital. And it's not great to send them off to a hotspot where they must recover if the risk of getting the disease there is actually bigger than staying in hospital. Consider screening all patients before their appointments in your surgery. And the screening doesn't necessarily mean testing, but make sure that you take everything in consideration. Travel history, having a fever, having a cough, having a sore throat, and things that we test every day and that we go through if we enter hospitals. Healthcare providers and staff are to wear surgical masks at all times. Make sure that if you're working with aerosol transmission procedures, that you have an N95 mask available. And I think also not only by request of the government and the president, but we should make sure that all patients should wear a face cloth under all circumstances. And that can be one that is made at home or one that's actually approved. So as long as they have that protection. Phase 2, that is the immediate preoperative period. In other words, the day or the couple of hours preceding the procedure. I think it's important to review the nursing, the anesthesia, and the surgery checklist for potential to revisit whether the patient might have been symptomatic, if the patient haven't gone into self-isolation. Make sure that you're up to date and don't just accept what was there 1 week ago is still the same. In phase 3, which is the intraoperative period, I think it should be reviewed on an ongoing basis, whether there's timeouts and briefings that need to be revisited, not only to the COVID-19 risk, but also in terms of the PPE use guidelines and that they are being followed. Review your waiting time during theater changes to make sure there's enough time for air circulation before beginning. And also make sure that you have a good specimen pickup protocol in place in your local institution. Then the 4th phase is the immediate post-operative period. And I think the most important part here is that should be standardized care protocols, because certain surgeons have different opinions and certain different ways of looking after their patients. I think if you deal with a pandemic like the COVID-19, one should actually just make sure that there's no confusion amongst the nursing staff. So I think standardized care protocols should be in place. And then the last phase, phase 5, is the post-discharge period. Make sure once your patient is discharged that they discharge into a safe area and that there is acute care facility available. Make sure that it's safe for them. Certainly if you discharge somebody to an old age home, those are not an ideal place if they don't have care and they can't go into certain amounts of isolation. And if you decide to discharge the patient to a home setting, make sure that there's safety and good care to look after that patient. So in conclusion, I think sensible communication is critical. And that should be not only amongst ourselves, but also the associated healthcare workers, the hospital administrators, to make sure what is the most appropriate clinical pathway for all patients. Remember, one should not only take considerations the safety of the patients, but also that of your healthcare workers and your colleagues, and also the administrators working close by. And I think one very important point, that this document that we produce is in no way a prescriptive binding document, and it does not provide medical legal cover. This is a document to give guidance, and we asked all the surgical societies, all 21 of them, actually to bring out specific guidelines for the procedures that falls within their surgical discipline, to make sure that if you do a knee replacement or you do a cesarean section, that you take these principles into account and that you actually do the thing that's actually prescribed and conveyed by your society. So the document was put up with the references as up there. And this was done on behalf of the FoSAS Council. And I just want to thank Martin Brandt, Paul Goldberg, and Philip Matley for the input of this document. and I'm quite happy to take questions afterwards. Thank you very much, Hlombe.
Thank you very much, Johannes. I'm used to facilitating in open forums, and I almost asked people to give you a big round of applause, but obviously you're not going to hear that. But that was very informative. There are a few questions that already were sent, but we're just going to give JP time to give his presentation, and we'll address those questions. So don't disappear. I'd like to hand over to JP.
As Hlombe mentioned, I'm going to touch on the ethical and legal implications of COVID-19. And just as a disclaimer, this is in no way an attempt to deal with any of the claims. I think that was covered quite appropriately by Johannes. And also, in the interest of time, we'll deal with things that we find to be quite or the most relevant. And the way that this presentation was structured was really around the questions that were submitted as part of the registration. Naturally, if you have any other questions, please feel free to ask them, and we will try our best, given the short time, to address any of those questions. So, I'm going to cover two main topics in the segment. The first being informed consent, dealing with the COVID-19 issues specifically, and then telehealth, which is quite a hot topic. And in the second segment, we'll look at the obligations of practitioners, and then lastly, we'll talk about questions. But as part of each topic, the one which features in both that I'll deal with upfront is what the law says. So without further ado, let me just jump into that. So the first starting point is, what does our law say? And what I find quite useful is to always start off with the Constitution, because we live in a constitutional democracy. So Chapter 12 is the fundamental Constitution, which protects your rights in terms of the Bill of Rights. And it basically affirms the democratic values of human dignity, equality, and freedom. Now, in light of that, the effect of the national state of disaster has basically limited certain of those rights. For example, your right to freedom of movement, etc. And really what amounts to is a balancing act, which is not something that's absolute. It's really in a justifiable way. So, for example, your right to your right of movement is restricted for justifiable reason because of the contagious nature of this disease. So one can understand why in certain circumstances there is this justifiable limitation on your rights. Looking at some of the other legislation or pieces of legislation that's applicable, obviously we know about the Disaster Management Act of 2002, as well as the regulations that have been issued recently. And I'd just like to draw your attention to a few of them. Section 27, 2 of the Act empowers regulations to be issued, which is what we've seen in the last few weeks. Regulation 11B is basically stating that all businesses must cease operations with the exception of essential goods and services. Now, essential services is really what I'd like to talk about, and I'll get to that in a minute when we look at the Labor Relations Act. And then Regulation 11G talks about any person who contravenes the regulation shall be guilty of an offense or potentially liable to a fine or imprisonment. And that's important to keep in mind when there are these national guidelines and the regulations that one has to follow. The next one is the National Health Act, for obvious reasons. Section 5 talks about healthcare providers may not refuse a person who requires emergency medical treatment. Section 23, subsection 3, requires every healthcare establishment must minimize the injury or disease transmission. And then you've got 2 sets of regulations that are also quite relevant. The 2012 regulations, which dealt with blood and blood products, essentially saying that in a time of this type of crisis, one cannot just use blood for matters that are not required. So, for example, where there's a basic hold or a sort of lockdown as we have it in today, then one cannot just use blood products and blood in certain surgeries. In 2017, there were regulations issued with regard to notifiable medical conditions, and COVID-19 is one of them. So basically, it puts an onus on you to notify the authorities if you suspect anyone of being a candidate or COVID-19 case. The Health Professions Act, Regulation 14(1)A, which provides for conditions of practicing as a medical specialist, is obviously also something very relevant. We then move on to the Occupational Health and Safety Act, Section 8, an obligation on employers to provide safe environment. And it doesn't only pertain to a hospital and hospital staff scenario, but also even a surgeon and assistant surgeon. So this features, this becomes quite relevant as well, the Occupational Health and Safety Act. The Labor Relations Act basically defines what the essential service is, and it's basically a service where the interruption of which endangers the life, safety, or health of the whole population. The public act necessarily relevant, but the Treasury to that act is applicable in one of what the potential liability for a private practitioner seeing as a patient. I'll try to get that into at a later stage, but essentially this is the act that features because essentially the state grants an indemnity to healthcare practitioners who provide services in the state facility. So our view is that this regulation should become applicable, and on that basis, you should be able to indemnity from the state. HPCSA ethical guidelines, there's numerous guidelines that are applicable, but draw your attention to one, two. Booklets 1 and 2, EthiQal 21, which talks about the performance of professional acts, and we'll get to that in a minute. And then also Rule 27, capital A, the main responsibilities of healthcare practitioners, and that features when we deal with difficult ethical questions. So just in terms of dealing with the issue of informed consent, even in a situation where we have the COVID-19 pandemic, basic requirements of informed consent still feature. So first three, or the first one is that the patient must be competent, the patient must have sufficient information to make a choice, and the patient must be able to give his or her consent freely. Now, none of that changes in the COVID context. And so it's worth remembering that these are the basic requirements that one must follow when undertaking the informed consent process. And what I always tell practitioners is that it's not, informed consent is not simply just a signature that you fixed to a document. It really is a process, and any court scrutinizing the informed consent procedure basically looks at how the whole process unfolds from the time that you first see the patient, what sort of information that you've obtained from the clinical history, what is relevant to that patient, and what is the material risks to that patient. So that's very important to keep in mind. Dealing specifically with the issues of COVID-19, and you'll see I've just sort of sub-questions based on the clear questions that we've seen. Should I supplement my existing consent forms? Would such a consent waive your constitutional rights? I think that's something that lots of people have asked. Can you force a patient to have a COVID-19 test? Now, it's important to understand that even when dealing with a COVID-19 situation, all the ethical principles that the HPCSA and the guidelines enunciate are still relevant, and one should still follow those guidelines, whether it's the need for privacy, confidentiality, record keeping, etc. Those must still be followed. When it comes to seeing a patient and taking consent for urgent elective or emergency medical treatment during the pandemic, you must obtain confirmation from the patient that they are not presenting with any symptoms of COVID-19, and that they will inform you should develop the symptoms. And I think it's also important to address two main issues or sub-issues on this particular topic is that the one is that as part of the supplementation of your informed consent process, you have to obviously discuss the potential risks of COVID-19. But at the same time, there's also the issue of consent to the actual COVID-19 tests. And I think those are two important things that one has to also keep in mind. So it's important to keep in mind that although patient confidentiality is an important principle in respect of the doctor-patient relationship, this obligation is slightly displaced in the light of the pandemic. And what I mean by that is that in terms of the regulations, practitioners must report any positive test results for COVID-19 to the National Institute for Communicable Diseases, NICD. And if I recall correctly, I think section Regulation 4 of the Disaster Management Act also prescribes that tests must be performed where there is a suspected case of COVID-19. There you can already see that that is something that's slightly different to our usual way of dealing with patients. And then COVID-19 is a notifiable disease, hence the law imposes a mandatory limitation to confidentiality when a patient is diagnosed with the disease. In addition, Regulation 11H5 of the Disaster Management Act states that no person may disclose any information contained in the COVID-19 tracing database or any information obtained through this regulation. So even if a patient tests positive, that doesn't give you a blanket entitlement to actually disclose that information to any other third party. Your obligation is to notify that to the NICD. That's basically where it stops. Obviously, if there's risk to the family or anyone else in contact, the NICD should then jump in. With regard to the question about supplementing your existing informed consent documentation, the suggestion is that you should incorporate the following to demonstrate that the patient has an understanding and an appreciation for the following things. A lot of these things may seem obvious, but it is important to keep in as part of that process. Even if it's not in a written format or separate document, you should still follow that as part of your usual informed consent process and at least document that in your clinical records. So the first is quite an obvious one, the contagious nature of the national regulations and guidelines. 3, no guarantees can be made, obviously with regard to the procedure and the fact that they won't catch COVID-19. 4, screening surveys prior to the consultation, treatment and procedure. And Johannes did make a very important statement as well, that one has to emphasize that retesting might be necessary as well. Any positive results for this screening survey may necessitate COVID-19 tests. Positive results must be reported to the NICD. Adherence to practice-specific protocols to protect you, the patient, and the public. And that can be whether the patient must sit in the car before they come into your practice, etc. 8, physical examinations and investigations and procedures require close proximity to the healthcare practitioner, theatre staff, and the patient. And lastly, that the cost of care may differ because of the nature of this disease and the fact that there's screening and tests, might be some delays. And as we heard, maybe there's a procedure that might have to be even delayed even further because of the long wait or the intervening period from the initial test. And also very important is that there should be an appreciation or an acceptance of the risks associated with the proposed treatment course by indicating elevated risk of obtaining the virus. 2, non-urgent healthcare is not recommended. And 3, that he or she is seeking treatment for an urgent condition. Okay, so the next aspect is telehealth. The question is by requiring consent for telehealth. Can I see a new patient and what should I consider before carrying out a consult? I think by now most people have heard that the HPCSA have relaxed only for the COVID pandemic the booklet on telemedicine, and it's now been changed to telehealth in light of this pandemic. So there are a couple of things that one has to keep in mind in view of the national state of disaster and the need for social distancing and self-isolation. The HPCSA has recently released a telemedicine guideline that is applicable during the COVID-19 pandemic. It states that telehealth should preferably be practiced in circumstances where there is already an established doctor-patient relationship, and for obvious reasons, because it would be quite difficult to see a new patient for the first time on a technological platform. Obviously, there are certain safeguards. If you can obtain the records of that patient, then by all means. And there are a few things that one has to consider whether suitable and appropriate. The first is that the particular technological platform is to be something that's appropriate, because as you know, even with our Zoom meeting over here, there are occasions where you run into certain technical glitches. You must be able to reliably identify one another, both practitioner and the patient. 3, that you should indicate to the patient that the particular session might be recorded for record keeping purposes, like you would with any other health record. The particular use and the recording of that forms part of your clinical record. 4, if there is a third person, a third party or chaperone that wants to attend, you need to get this consent in writing and document that as well. Also, when considering or weighing up the option of having either a face-to-face or a telehealth consult, you have to keep in mind a number of considerations, whether it's appropriate, suitable, if it's a new patient, etc. Do you have access to the medical records? And when you make that deliberation, you need to document that in your clinic, because obviously just later on and whether it's the regulator or anyone else scrutinizes that decision, you have to be able to defend that decision. Also keep in mind that you probably need to have a contingency place for referring that patient to another practitioner for a face-to-face consultation if it turns out that you're not able to suitably consult with that patient. Verbal consent, the actual telehealth consultation is fine. You don't necessarily need written consent for that, because you can do it easily over the particular platform, and you can just document that in your records. When one has to consider weighing up whether you should do a remote consultation as a face-to-face one, there's a useful guideline that one can find on the GMC website, the General Medical Council of the UK. And I've put in a link there for that particular document. It's a very useful tool that one can use when being confronted with that decision. Okay, so now we're moving on to the rights and obligations of practice. And the first thing that crops up is the consideration of working outside your scope of expertise. The questions here that are posed: can I perform duties that fall outside my scope of speciality? What should I do in an emergency? And can I refuse if I don't feel competent? And these are quite valid questions. The first thing is to consider Regulation 14.1a of the Health Practitioners Act. And basically that regulation specifies that medical specialists can only practice within their particular field of expertise or speciality. And that obviously makes a lot of sense. But in this particular scenario that we have with the COVID-19 context, it's, as you know, highly likely that many clinicians will be asked to support the response by performing duties that they would not normally undertake. Now, one has to then weigh the sort of the considerations now, having been told that you can't work outside of your particular speciality, but on the one hand, you've also been asked to perform duties outside of your normal expertise. EthiQal Rule 21 deals with this quite definitively. In terms of the guidelines, it says that your obligation to only act within your registered scope of practice falls away during an emergency. Do not provide emergency services where you feel insecure about your skill set to the extent that potential harms might outweigh any benefits. When in doubt regarding your ethical obligations in such situations, consult the Ethical and Professional Rulebook, Booklet 2, reading Rule 21 in conjunction with Rule 7, capital A, which I mentioned earlier. 27A talks about the main responsibilities for healthcare practitioners. So this means that your usual scope of practice restrictions do not apply when you render emergency services. But just keep in mind that this doesn't necessarily mean that you can act out of your competence. If you feel that you are not going to perform a particular task, then by all means, rather don't perform those or carry out those duties. Okay, next one is safety. Can I refuse to see patients if there are no suitable PPE? And what should I do if I fear a patient's care might be compromised? So actually, in situations like this, you are worried that your working conditions and environment during this crisis may be unsafe. We've all seen the reports in the news that there is a shortage of PPE. This is a global pandemic. Everybody is looking to acquire PPE. So there is a high risk that systems in the healthcare sector might fail, whether it's the medical risk or the risk of contracting the disease or just operational systems failing. It would be wise to discuss contingency plans that are in place so that everybody has a clear understanding of the risks and procedures put in place to protect staff. If you are worried that patient safety or care may be compromised, you should raise your concerns with other clinicians, and those conversations, you should consider them, deliberate on them, and document those deliberations. Because again, as in the previous segment, whenever there's a decision that you've made that is going to be scrutinized, your deliberation on that issue is quite important. So make sure that whatever consideration that you've taken, whether it's referring it to a more senior colleague or discussing it with hospital management, make sure that those deliberations are documented. And lastly, also just keep a record of any discussions about the problems you have faced and the steps that you have taken to remedy those matters. Provision of appropriate PPE supply should be an institutional priority. Infection prevention and control measures for healthcare workers caring for suspected COVID-19 patients. Do not see patients if you do not have sufficient equipment to protect yourself. Where possible, carry out a teleconsultation for COVID-19 patients in order to lessen the risk to staff and other patients, including yourself. If you have pre-existing health conditions that place you at increased risk of infection, to discuss working arrangements with colleagues or your employer. It might be appropriate to ask a suitably qualified clinician to take over the care of that patient. Ethical decisions is something that will crop up quite often. We've heard examples of people sort of bringing up hypothetical situations. If it hasn't occurred already, by surge in the number of cases. I think the last time I heard it was anticipated to be September. But we've certainly seen that what happened in Italy has given rise to a lot of these type of questions. People have asked, how can I ensure that my skill withstands scrutiny, and are there any resources available to help me? So in front of a difficult ethical decision, your first port of call is to consult booklet 1, and you'll see that there's an X there, how to resolve ethical dilemmas. And that's a very, very good resource to work through systematically. First, formulating the problem, consider the options and model assessment. And again, I consider this with difficult decision, gaining input from the colleagues and weighing up the various options. Always document those deliberations. Number 2, the NICD have developed clinical guidelines and FAQs, and I would encourage you to refer them on their website. And then SARM have also prepared useful guidance for managing ethical issues. And then lastly, when faced with challenging clinical decisions, doctors should continue to familiarize themselves with existing protocols, get a second opinion about diagnosis, treatment options, etc. And then practice is something that is quite close to everybody's heart. What happens if a patient contracts COVID-19 in your rooms? How can they succeed in a claim against your practice? And can patients claim COVID-19 as a force majeure? Just for those that don't know what that means, it's basically, there's interchangeable references to that. But basically it means an instance of supervening impossibility of performance. And essentially, one cannot perform a particular act. But just dealing with some of the medical-legal implications, there is obviously a concern that one could potentially be held criminally liable for assault, attempted murder, or murder if a practitioner or their practice exposes a patient to COVID-19 and that patient then dies. But the important thing to keep in mind is that for any of the aspects, one has to demonstrate intention. So you can't succeed in criminal liability for assault, murder, or attempted murder without that crucial element of intention. In the case of, it was a recent case of Nhawu versus Minister of Health and others, it was a Labour Appeal Court case. Essentially, it was an application that was brought by the union on the basis that the Minister of Health failed to take reasonable steps to minimize the risk of COVID-19 infection to healthcare professionals and support staff. Now, essentially, the court held that they weren't liable, but it was due to a lack of evidence. But essentially what the court confirmed, what was already stated in other numerous cases, is that an employer cannot be held liable for an employee who was injured on duty if the employer took reasonable care to prevent the risk of any illness or injuries at its workplace. The same principles apply in this particular setting. As long as you've taken reasonable steps, followed the national guidelines, followed the recommendations that have been made, then it'll be very, very difficult to succeed with such a claim against you. Obviously, as I mentioned, for assault, murder, and attempted murder, the element of intention is important. Whereas culpable homicide has garnered a lot of attention in the recent months for obvious reasons, but even there it contemplates negligence, not intention. And we've seen that quite, I mean, sort of the brazen act of SAPS was to arrest certain practitioners even when there was no inquest that will determine whether the doctor in question did in fact cause the patient's death. So the suggestion is that take all reasonable precautions, any suggestions, any guidelines, any recommendations that have been published, as long as you've complied to the best of your ability with those things and act responsibly, it'll be very hard pressed to find you liable for on that basis criminally. In a civil context, usually these claims are brought in what we call delict or tort liability, and there's 5 elements that need to be proved. But if one can show that you've taken all reasonable steps, that negates the element of negligence. As long as your conduct is sort of against the standard of what a reasonable practitioner in your circumstances would have complied with, then it will also be very difficult for them to succeed with a claim for liability against you on the basis of a intellectual action. Force majeure, as I mentioned, it's basically supervening impossibility. It's just a sort of a complicated way of saying that one cannot reasonably, there's an impossibility of performance, basically. Now, the question was posed in the context of whether a patient can use this as a defense to not pay your bill. So the question is, will the coronavirus constitute a force majeure under certain typical that it all depends. It depends on your contract with the patient in terms of your terms and conditions with the patient. I doubt that many contracts would include a force majeure clause. These are usually clauses that feature in long-standing commercial transaction agreements. But if such a clause doesn't exist, then the common law would apply. And there is a whole set of criteria that one has to comply with in order to prove that the COVID-19 situation constitutes force majeure. The point here is simply that there is a set of criteria and requirements that need to be made. So for the patient to then invoke that, or to say or claim that there's now been this break or this force that's allowed or that's created this impossibility of performance, then they would need to prove those things. So just because they claim that doesn't necessarily mean that you can't send a bill. Like I said, it's for them to prove that requirement, that element. So I deal with a lot of, and the talk was really structured around questions. Obviously, I couldn't deal with all of the aspects, but I hope that I covered most of them. To the extent that I haven't, my apologies. So that's basically the end of my presentation.
Thank you very much, JP. And again, I would like wherever we sit, let's give JP a round of applause. Hopefully that he can hear it. Thank you very much, JP. This has been a very good presentation, and I think it has been very valuable to all the people that have attended. There are a few questions that I would like to put through, and I want to start with the ones that have been written right now. I'm just going to read them as they are. I am concerned that it appears that no consideration whatsoever is given to the mental health of patients. This has always been an issue, but in the present situation, where hospitals allow no visitors, this should be a very important consideration. I think if you take that question and you take the relationship between the doctor and the patient, the responsibility of the doctor goes beyond just the sickness. I mean, orthopods might be looking at a fracture, but you look at the total well-being of this patient. Any comments on that? Maybe let me start with Johannes. Johannes, you have to unmute yourself.
Yes. No, maybe I can comment on that. I think we've had at our local facility, I think a question like that. And the problem there was that one of the patients were actually terminally ill. But it was a cancer patient who actually had respiratory symptoms, and they were not sure whether this patient actually had COVID-19. And then the decision by the hospital is, as a blank rule, that no visitors should be allowed. And I think this was debated on our local level, and I think that's something that should be addressed. I don't think one can do a blanket policy, but I think in terms of this, if you have to put the risk out there to the near family, if they want to visit the grandfather or the father or the family member, but I think there should be, but that should also be considered in terms of the local conditions. Obviously, if it's in conditions where the whole hospital is full of COVID-19 patients, you will take a different decision from where there are 1 or 2 patients in the hospital, and even some of the hospitals where there are no patients there. So I think it is a very important consideration in terms of our field of maternity. Certainly at this point in time, due to our local conditions, we still allow the partners in, but I think no other visitors, because I think if you get too much trafficking, you do actually increase the chances of the patients in hospital also to contract that. So I think it's something that should be individualized on a local level, but I think it's a very, very important thing that one should consider.
Thank you. Thank you very much. And from a legal point of view, JP, in that case, what happens if the visitor contracts COVID? Now the hospital is supposed to give all the precautions, But, is there some legal implications for me as a visitor that's visiting my relative at the hospital?
Yes. So, I mean, in a situation like this, I think one assume that everybody understands the serious contagious nature of COVID-19, and if you have a relative in the hospital, it would be almost an assumption of by going into that hospital, a family member, you run the risk of picking an infection. The liability would fall in the case of any other infection where there should be certain basic requirements for infection control. So usually that type of liability would rest with the hospital facility.
Is there something that I can do as a doctor to protect myself?
Well, I mean, all that's required from you is to take reasonable steps. There are many suggestions out there. I've seen a few. Some have published quite a nice document talking about how to get ready, how to get your practice ready, after the COVID-19 pandemic. Suggestions like having patients wait in their car, not coming in, ensuring that your reception desk is situated a certain distance from patients, these type of things. And those are reasonable steps that one has to comply with in order to ensure that there's no transmission of that disease. But again, as I mentioned earlier, there are statutory obligations on practitioners to ensure that you do whatever you can to minimize the risk of disease transmission.
Okay, thank you, JP. There's another question about if a staff member tests positive and the name of the staff member is requested by another member of staff. Here's an example. Here is a healthcare worker in the hospital tests positive. And now another staff member who did not have contact to this one that is positive says, please tell us, who has tested positive. Firstly, the one who is asking did not have clear contacts with this positive one, and also is not going to be involved in the treatment or in the management of the positive staff member. As a healthcare worker, can I just give that name to whoever is asking? Or confidentiality is still something that we need to take care of? JP?
So confidentiality still is right. It's important. That particular person who's asking for that information is not entitled to that information. I don't see anything in that particular scenario that entitles them to that information. Obviously, if there's a possibility that they're at risk, if one can reasonably assume that they are a suspected COVID-19 case, then they would be entitled to that information. But for the
would it not be that because COVID, or if a person tests positive, that's a reportable disease, or that's a reportable case. By the mere fact that you've reported, it doesn't necessarily mean that you have to disclose the name of the patient. However, you would say that in this hospital, we had a healthcare worker who is actually positive. And therefore, whoever was in contact directly with that person, or maybe the surfaces where that person was working on, they need to be tested. So what I would take there is that you don't need to tell that particular person. What you need to do is to make sure that the case is being reported, via the appropriate regulations. Then, the way to manage it will be taken over by, the guidelines that are actually out there. Just to make sure that we are on time, There are a few questions that I want to pose to Johannes. Should elective pediatric surgery be stopped during a pandemic that mostly affects adults? Your comment, Johannes? Pediatric surgery, should we just stop it? This thing is more common to adults.
I think the broad guideline would be depending on the urgency, and I think I've given the four levels of surgery that we consider, but that depends on the local circumstances. I think if there's a lot of COVID-19 patients like in Cape Town at the moment, I think one must be very careful if you're not going to attempt something that's really life-threatening. I think it's something that should be in those classes, and you should weigh up the benefits and the risks. I think if it's an area that's a little bit quieter and doesn't have as many cases, I think it probably can continue. But we must remember that one should leave sufficient capacity in your healthcare institution if there should be a sudden sort of overwhelming admission of COVID-19 patients. But most of these institutions have a COVID part and a sort of non-COVID part. So I think to say a blank policy, all pediatric surgery should be stopped, I don't think that's the correct way to go. I think it should be carefully considered, and the ones that should go ahead and is reasonably safe to go ahead, taking benefit and risk into consideration, can continue.
Okay, thank you for that. The other question, and this question has been coming to us in various ways. The one is there real need to do your pre-admission screening and testing? Actually, let me put it differently. The pre-admission testing. And, you know, the questions they come, I mean, I think we had about 3 questions that were talking about the PCR test. Is it something that is needed? Or is it screening that is just important? You know, what's your comments?
Yes, I think that's also something that depends on local availability. I think the ideal would be to have a 100% accurate test. You know, don't have any false negatives, and that's the ideal. But unfortunately, we do not have that. Now we know that 30% of patients actually that do have the disease are actually asymptomatic. But it also means if you're asymptomatic, that probably your viral load is not that high. So to have testing done, I think has its uses if it's available, if it's quick, turnover time is quick, but you cannot accept that it's going to be 100% accurate. But certainly if you test positive, it gives you the idea, it gives you the opportunity actually to cancel an elective case and do it at a later point in time. I think it also boils down to the medical-legal part of that. So if you do not test and the patient contracts the disease and there's some adverse outcome, that you can actually expose yourself to some probably legal actions. So the short and the sweet, I think it's good to test. I think it depends on the availability in private practice at the moment. Most of the hospitals would require you to test before the time. But I think in the public institutions, because of the high volumes, it's probably not practical at the moment to test indiscriminately. But I think from a medical legal point, JP can probably enlighten us a little bit more.
Yeah. I think the question that comes again on that is, if the patient refuses a test and the patient, you know, you can see that the patient from a surgical point of view requires the surgery, but refuses to test for COVID. You know, what can I do as a doctor? Can I just say, look, you know, you've refused this test, therefore I don't want to expose the whole other healthcare workers to the unknown? Or do we go ahead? What do we do there?
I think from a medical point of view, I can maybe comment, but I think JB's comments will also be valuable. If you have reasonable doubt and you think the patient might actually put you at risk, and I think having a 30% post or asymptomatic positivity, I think it could put healthcare workers at risk. And we must remember the people in the front line are the healthcare workers. So if a healthcare worker goes down positive, you take a lot of other healthcare workers around you, also out of the system to care for the population and the other positive patients. And I think probably it could make a very strong case to say that that specific patient who actually does not want to test potentially exposes a lot of healthcare workers in the front line of not being able to do their job should it be needed. And I think it's perfectly within the rights of the specific doctor to say then in that case, if it's not really a life-threatening surgery, to postpone the surgery. If it's life-threatening surgery, certainly what one must do is one must protect yourself to the extent that you use full PPE as if the patient is positive. But I think from a medical legal point, I think JP's input will also be quite valuable.
JP?
The disaster management regulations do provide that, and it says persons who have been confirmed as a clinical case or as a laboratory confirmed case as having contracted COVID-19, or who is suspected of having contracted COVID-19, or who has been in contact with a person who is a carrier of COVID-19, they have to be tested, and they cannot refuse medical investigation, testing, or quarantine and isolation. Now, in a way, that almost implies that informed consent is not strictly necessary for purposes of testing and treating COVID-19 patients. But I must mention that, as I mentioned earlier, the 2017 regulations, notifiable medical conditions, COVID-19 is one of them. And it therefore puts a statutory obligation on you to notify the NICD or any other authority that this person's a suspected case. And for that reason alone, I would suggest that your obligation is to not then go through with that procedure if that person is suspected of COVID-19.
Okay. There are general questions that are coming through. In terms of, the relationship, you've got a doctor-patient relationship, and the doctors are themselves looking at the clinical conditions of the patient. You've got a hospital on the other side that has got its own principles, that has got its own guidelines. The questions that are coming through that in some cases, and these are real issues that are taking place now, in some cases, the hospital groups, they've released certain guidelines that are in contrast with, or they are in contradiction with the clinical principles. Where does liability lie? I'm throwing it to
Maybe
both.
I can come in there quickly, Hlombe, and I think JP will probably be better to comment. But I think the hospital groups that certainly we've been in contact in, and those are the big hospital groups, have actually taken note of the consensus statement that we put out there, along also very importantly with the anaesthetist, the FoSAS statement. And I think most of the principles of the hospitals are based on the principles lined out with these two documents. All the organizations, different societies have put out their guidelines as well. I think the hospital groups that certainly we've worked with are quite susceptible and quite willing to look at those guidelines from the society in actually making their own guidelines. So I haven't seen any really principles that clashes in those documents of the hospital group. Sometimes they're a little more cautious to make sure that they probably don't get into medical legal action. But I think there's always been a fairness and taking consideration of the society statements that's come out. So JP, maybe from a medical legal side, can comment further.
Yeah, I do agree with what Johannes is saying, but it's important to also keep in mind the autonomy of independent practitioners, and one has to always keep in mind the ethical rules that govern your professional environment. That practitioners are independent and they have to exercise their judgment independently, free from any favor or prejudice or anything to that effect. So that is just my comment on that, because ultimately, if something does become a medical legal issue, your conduct is scrutinized.
Thank you very much, JP and Johannes, for the questions. I've got two last questions before we come to a close. And I'm throwing that question to any of you. Why are medical aids not wanting to pay for COVID tests?
Maybe I can come in there. I think there is some negotiations and quite a lot of negotiations from the SAPAF, the Private Practitioners Forum, with the medical aids to pay. Because I think at the moment the people smiling, or some of the few people smiling, are the medical aids, because medical contributions are ongoing, but people are not claiming from them. So I think there is some responsibility from the medical aids to pay for those tests if they are done under reasonable circumstances. And certainly one of the hospital groups I know have actually declared that if the medical aids does not pay for a test, and if the patient is not willing to pay, that they are willing to pay for those tests, because if somebody has the disease and they do infect some of their hospital workers, it will also have a big impact on the hospital groups themselves. So I think, short and sweet, I think there will probably be somebody that will pay for those tests, and I think in principle it should be the medical aids, and I think we're putting some strong pressure on them to come to the party.
Last one, JP, it's your question. How long are we going to be on the lockdown, JP? Yeah. Maybe let's keep that until the president says, fellow South Africans. You would have noticed that I didn't ask any questions related to obstetrics or gynecology. We had several of those questions. That was a trick, only because all the gynecologists and obstetricians that are attending today would like to invite you next week, same time, same place, where we will be hosting the president of GMG and SASOG. We'll really be focusing on dealing with obstetrics and gynecology matters. So I said, I'm not going to answer those questions. There were a few other questions that were submitted, and we will address some of them because some of them did not fit snugly into this presentation. And also we're looking at our time limitations. So without wasting a lot of time, I'd like to thank Johannes and JP, and with this very informative presentation. I was really concerned because I think it was 2 weeks ago or last week, the Zoom meeting of government was actually interrupted. So I was thinking that, please, this one should not be interrupted by those kinds of things. But it seems that everything has gone very well. And thank you very much. I see that at the most we had about 142, 149 people that actually logged in. We'd like to thank you all for your time, and we will continue addressing these issues. Maybe instead of just waiting for us to have these webinars, we are open to all our members. Send to info any other topic that you'd like us to discuss so that we can arrange all of this. Without wasting a lot of our time, my time is 2014, and I would like to thank everybody that has attended. Please don't forget to send your MP numbers and your names and surnames for those that did not register so that we can send your CPD certificates.